Hey everyone, I'm Leif Nelson and thanks for coming to the Data Colada seminar series. It's my pleasure to introduce today's speaker, Ziad Obermeyer, and our wonderful panelists, Hamza Bastani, Kate Bundorf, Alex Rees-Jones, and Stefano Della Vigna. In addition to all of them, we have Joe Simmons and Yuri Simonson, who are joining us as always. For those of you who haven't been here for a presentation before, you'll see at the bottom of your screen, there's a Q&A function that is the best way to submit questions or comments to us. Ziad is presumably going to be too busy talking about his work to be able to read them, but fortunately the rest of us can read them and we will give voice to them when possible. And even if we don't worry, they're recorded and they will get to him at the end of the presentation anyway. Cool, so that's about it. The floor is yours.
Thank you so much, Leif. So I'm going to talk about some joint work that I've done with Sundal Mulanathan at Booth on the topic of physician behavior and what we can learn about it, and in the process, learn a little bit about our healthcare system. But I wanted to start with a question about machine learning. So this is a central tool that we use in this paper. And I think that when you look around, all around you in the world, online and offline, there are all of these ways in which machine learning is doing amazing things for how we navigate through traffic, how we buy stuff, how travelers are tested when they go to Greece on summer vacation, for example, in Hamza's fantastic work. And I think all of that is useful and kind of really great. But at the end of the day, sometimes you start thinking like, well, is this just like kind of a neat new trick that we can use to help us, get to our destination 10 minutes faster? Or is there some deeper thing that I can learn from this new tool? And I think that the answer, at least for me, is yes. And I think this is part of what I find so exciting about applying machine learning to healthcare and elsewhere, is that we can actually use it to learn, not in the way that I think people typically do that, which is like, oh, can we open up the black box? But in fundamentally different ways. And so today I want to talk about two things that at least I learned from machine learning when applied to the healthcare system. One is about where low value care and inefficiencies come from. And the second is about how physicians think. So the running example that I'm going to use is a dilemma that doctors in the ER and doctors in any part of the healthcare system face when a patient comes in with any one of a number of symptoms. Now, sometimes that's chest pain, but sometimes it's more subtle. Sometimes it's shortness of breath, a little bit of nausea. And the reason that's a dilemma is because lots of people come into the ER or elsewhere with those symptoms, but it could be a heart attack. And one of the surprising things that I learned in my clinical training is that heart attack doesn't typically look like what it does on TV. It's not always someone clutching their chest and keeling over. It can be really subtle. And so you've got this very tough trade-off to make, because you can't really test everybody for a heart attack. Otherwise, these symptoms are so common. But on the other hand, for the people who have heart attack, you really want to test them so you can get them care and identify them. And so the central decision that the physician has to make, at least for this narrow problem, is, do I test for a new blockage in the coronary arteries supplying the heart? So when I say heart attack, that's the kind of colloquial term for a clot that forms in the arteries that supply the heart muscle, that if not treated, lead to the death of a little patch of heart muscle. And that can lead to sudden death, and it can lead to a number of long-term complications. The way we diagnose those things is by, there's two main ways we do it. One is we can send someone to run on a treadmill and measure, when I increase the demand on the heart, does the supply of blood compensate, or is there indirect evidence of a blockage? But the definitive test is you have to send someone to the operating room and insert a catheter into their heart and directly look for a blockage. That's also how you treat the blockage. So as you can imagine, especially that definitive test is invasive, it's risky, it's expensive. And so, that's where the constraint comes from. So we're allocating some scarce resource. This is a problem that's familiar to all of you, but it's a really hard decision. So that's the decision we're going to focus on today. So I wanted to maybe start by just laying out a very simple model of testing that we're going to use in this to kind of understand this decision, which is that, imagine yourself in the ER. You're the doctor, and you see this kind of set of patients coming in. And each one of those patients has some probability of blockage. And that's a function of two sets of variables. X variables that we see as the kind of policymaker or social planner, and the Z variables that only the physician sees. So these are the things like, how does the patient look? Are they pale? What do they say when I ask them a question? So if I test that person, then I find the blockage, if present, and the patient gets this huge benefit. So there's this large literature from randomized trials spanning like 3 decades that shows that for people with a new blockage, if we can diagnose and treat them in time, the returns to life expectancy and health are just enormous. So that's the kind of like, if I test them. And if I don't test them, then another thing happens, which is that there's some increased probability of adverse events that can manifest, in the future. And taking the clinical literature into account, the real danger zone for those things is about in the month after the heart attack. So that's the two things that can happen. If you're tested, you get the test, we see the result, you get the return. If you're not tested, then we may see these adverse events over the next month, and that has a cost. So what's the socially optimal rule? Well, obviously, the socially optimal rule is to say, okay, well, there's some threshold at which cost equals benefit, and I want to test people who have a benefit greater than cost, and integrating across all of those financial costs, the risks, the complications of the procedure, things like that. And the core insight here is that only positive tests really have benefits. So if I do a negative test, or if I do a test and it turns out to be negative, I've exposed that patient to all of the costs of testing, but they get no benefit because now I'm back to where I started. They don't have a heart attack. I still need to figure out what they do have. So a negative test only cost, positive test has benefits. So that's the kind of like the socially optimal rule. Now, what's the physician testing rule? Well, this can be a little bit different in 2 ways. So the socially optimal rule is test if the true probability of blockage given X and Z is over the threshold. The physician doesn't see the true probability of blockage. The physician has her own function of X and Z, H of X and Z, that she is using to estimate this same quantity. And the physician has another thing that's different, which is that the physician may have some kind of private incentive to do a test related to the structure of the insurance contract, the compensation that the hospital gets, et cetera, et cetera. I'm just going to black box all that stuff and say, there's this additional term on that side that could reduce the effective threshold that the physician uses. So there are 2 inefficiencies that can result from the deviation between the physician rule and the socially optimal rule. Number 1 is that H of X and Z is not necessarily equal to B of X and Z. So that misprediction of risk can have lots of consequences that are not optimal. And the second is that there's this incentive that torques the threshold down in favor of doing more tests. And this is the kind of moral hazard view of the world. So building on that.
Ziad, can I ask a quick question?
Yeah, please, Jeff.
I just don't know if this is going to matter, but you imply that negative tests have only costs, but I can at least envision some positive benefits. Like if you rule out heart attack, that might increase the probability of a correct diagnosis. I don't know if this is going to matter at all. But I just
So I think that the my somewhat facile answer would be, I'm kind of considering every medical condition as their own. You have a budget for diagnosing heart attack, and if it's not heart attack, then now you have to go do this other thing. So taking a narrow view of heart attack alone, I think, that's why I'm saying it. But in practice, you're totally right, because I might update on the probability of lots of other things if heart attack is negative. But in my formulation, it's like I've got a prior on this vector of things, and I kind of do them one at a time. And if I cross this one off, of course, it increases the probability of the other ones, but it's not super informative because I think of it as I'm back to where I started. Now, there's another set of benefits that's also definitely there, but we're assuming are 0, which is the psychological benefit to the patient of knowing that they don't have a heart attack. And so here again, a somewhat facile answer is to say, well, my prior that I had a heart attack is pretty close to 0 to begin with. So if I update to 0, it's kind of a rounding error. But these are all simplifying assumptions, and I think that they do introduce some distortions, exactly as you point out.
Can I ask another clarifying question here? So
Yeah.
the incentive always lowers the threshold, so there's no subgroups where physicians undertest because they have maybe a bad insurance plan or something like that?
Yeah, so in principle, the incentive can be, it doesn't have to be positive. It can be negative as well. And you might see this increasingly as we get risk-based contracts where the physician is incented. So yeah, I didn't mean to imply that it had to be positive in this case. It can be anything, but I think that the dominant way that we look at this decision, given the literature that tells us that the testing yield is too low, is that physicians test too much because of moral hazard. But in principle, yeah, it can be anything. Okay, any other questions on the setup? Because as you know, once you've accepted this, it's all over. Okay, so here's our tests. So take any set of patients that come into the ER. We're going to make the not very interesting observation that set of patients is either above or below the optimal testing threshold. We're going to define over-testing in a very specific way. We're going to look only at tested patients, and we're going to look at their yield. And if the yield of testing is below that threshold, which we're going to define in terms of cost effectiveness using standard assumptions from the literature, then that set is over-tested. The cost effectiveness of tests in that set defined by the yield translated into cost per life year. And there's a huge literature on this that we just kind of shamelessly steal from. That set is over-tested. And even though on average they're over-tested, there can be, there's a range of value within that set, but on average they're over-tested. And because on average they're over-tested, then cutting all of those tests would increase welfare relative to the current state of the world. So we're not excluding that some of those people could be, very good tests, but on average they're bad tests and we should cut them because they're below the threshold. So that's over-testing. Under-testing is symmetric with that. We're going to look at the untested patients and we're going to look at their adverse event rate over the 30 days after they go to the ER and don't get tested. And then the question is, well, how do we set a threshold? So we could have tried to map this back onto cost effectiveness, but there are a bunch of parameters that we don't know. And so we're going to look to a different literature for the threshold, which is clinical guidelines. So there are lots of papers that are offering decision rules and decision support to physicians that define the recommendation to test ex post based on the adverse event rate in a set of patients. So they look at untested patients, they say, well, ex post, these people turned out to be really risky in terms of their adverse event rate. You should have tested them. And so we don't necessarily assume that is the socially optimal threshold, but we do assume that physicians use those rules because they're very widely adopted and endorsed by all of these professional societies. So physicians would not want to leave patients untested if they knew that they were going to have an adverse event rate above this clinical threshold. So there too, we're going to say, even if some of those people would have been low value, on average, they have this rate of adverse events that's in excess of what all of the professional societies and decision rules recommend. And so testing everybody in that set would increase welfare. So those are our two definitions that we're going to use to empirically test for inefficiencies. And I just want to note that, and this is back to Hamza's excellent question, the moral hazard view of incentives, in other words, physicians have a positive incentive to test, can only lead to over-testing because you're dropping the threshold. You're already testing all of the people you should be testing, but you have this incentive pushing the threshold down, so you're testing lower and lower value people. You're diluting your yield. That's over-testing. Misprediction, because you can just, we're not assuming any correlation between the physician's risk estimate and the true risk of blockage. That can do pretty much anything.
Can I ask a kind of conceptual question on thinking about
Yeah.
undertesting?
Yeah.
So this is like this is not your paper. Here's attacking a straw man. But imagine I were writing a paper saying, oh, you know, moral hazard is all about over-testing. I look out in the world, they tested, you know, 100,000 people. One of them, they messed up. There was one person they should have done more testing, all the rest, you know, they were over-testing. So, I mean, under this definition, you could write the paper with like similar introductory paragraphs where, oh, moral hazard says you should always have over-testing, but we found some example where there's under-testing. That would be a silly paper. That's not your paper, but like we in that paper, even using the term under-testing would be like confusing, where they're over-testing and there was some mistakes. So where is the definition between, or where's the line between where you start saying they're over-testing with some mistakes and where you say under-testing that refutes moral hazard is like systematically a thing?
I mean, I think the paper you're describing does exist in the medical literature where, you know, I think that there are these anecdotal things that are like, oh, this person was a missed heart attack. All of these decision rules are wrong. They don't apply to my patients. Why should we? So, you know, even though that would be a silly paper, it is a silly paper. And so I think what we're relying on here is this idea that there is some threshold where, you know, you don't have to rely on anecdotes. You can actually say that there's a rate of adverse events that is not acceptable. And it's not, you know, 0.0001%. And so there's remarkable consistency across these decision rules in this kind of, you know, how many can you tolerate? It's also kind of like in these surveys of emergency doctors. So I think that that's the importance of saying, okay, we might not be able to pin down the optimal threshold for calling a certain event rate under testing. Here, we're actually just, you know, mostly interested in physician behavior and what they view as kind of like where the line is. And so let's just take the threshold that they would accept and let's see if there's under testing according to that definition. And I'm also going to show you some evidence about like actual health outcomes that I think will be very reassuring on that, about the size and the nature of under testing. But here, I think we're relying on these consensus definitions where we're just like, okay, you know, you're the professional societies, you've gone through some process to set a bound on what's the adverse event rate. We're just going to use that. And we're going to see if, according to your own definition, physicians are over or under testing.
Yeah, can I ask you one more question about the moral hazard point? So when you talk about moral hazard, it's kind of in the context of, you know, patient cost sharing or a fee for service payment system, you know, that's directly affecting the provider. If we think about ED in general, do physicians face those types of incentives, or are they something different? Are they like, I need to get many patients through very quickly. So maybe that would create a different incentive for me in this context.
Yeah. So I think that there are probably two sets of incentives for the emergency doctor. And I think that on a day-to-day level, you're probably right that like a lot of the incentives are basically related to like volume and speed. And so part of that comes from the hospital in the sense that like if there's a lot of capacity in the hospital, like a lot of hospitals have dedicated units to do testing for heart attack. So as an emergency doctor, you know, a great strategy to minimize the time you spend with patients is just to be like, well, I'm going to test them for heart attack. I'm going to send them out and they're going to. So that's the hospital incentives that are kind of torquing the decision-making of the emergency doctor towards over-testing. But it's the same underlying source. There's a different source, which is that I think on a day-to-day level, the incentive that emergency doctors think about the most is malpractice and kind of the risk of missed heart attack. It's missed heart attack and missed fractures are like two of the hugest preoccupations of emergency physicians because they're the most common sources of malpractice claims directed against emergency physicians. So I think that if I were to guess, that's probably the bigger one. And certainly if you look at the surveys of what the doctors are thinking of, that's the one that they cite as like the biggest kind of private incentive to do socially suboptimal things. Okay. So where does machine learning come in here? Machine learning is going to let us form explicit predictions on that B of X comma Z, on the risk of blockage. And that's going to do a very important thing for us in this paper. It's going to allow us to identify subgroups of patients, sets of patients that might have been over-tested or under-tested. Now, of course, we're going to do that based on X. And so what we're going to do is and it almost doesn't matter if you're using machine learning or some other thing. There's some function of X that identifies a set of patients. And then that set of patients can be either over-tested or under-tested. So the only role of machine learning here is identifying sets of patients based on X. And we're going to look at those sets of patients for evidence of potential error. We are not using the algorithm as the truth. We're not assuming that the algorithm is right. And we can't assume that the algorithm is right because the algorithm only sees X. The physician also sees Z. And Z is things like the electrocardiogram, the exam, all of these things that are actually very good and useful signals for risk or for treatment benefit, which are two categories of private information that we need to take seriously. So we're not assuming that the predictions are right. We're not saying, oh, if the physician deviates from the model, that's an error. We're saying we're going to look at candidate sets of patients, and we're going to consider whether they could represent errors based on health outcomes. In the tested, we're going to look at the yield of testing and the cost effectiveness of that. In the untested, we're going to look at the adverse event rate. We're not going to be imputing any outcomes based on the model predictions. We're just identifying sets and looking at real outcomes. So here's how we set up the prediction, and I'm going to abstract from a bunch of the details. But if you imagine the patient's trajectory, T0 is when they walk into the front door of the ER. Over the 2 years before that, we're going to construct a set of variables, and it's a lot of variables that are drawn from electronic health records. So it's diagnosis and procedure codes, laboratory studies, vital signs, like lots of stuff. That's a continuous time series that gets run through kind of like a machine and turned into variables, like 16,000 variables. And then over the 10 days after that visit, we're going to observe whether the patient was tested for heart attack with this set of tests like stress tests and catheterizations that are dedicated to finding blockages. And then we're going to observe whether or not that person was treated or not. So we're using treatment as the indication that that test showed a blockage and the blockage was opened up with a stent or with open heart surgery. So that's how the model works. We're going to use a continuous sample of ER visits to one top-ranked academic hospital, about 250,000 visits over a 4-year period. We're going to take out a bunch of people that just based on prior characteristics look like they'd have potentially limited benefit from testing and treatment. So anyone 80 years of age or older, anyone with like cancer or end-stage heart failure, or things like that, anyone who's in a nursing home or a SNF, palliative care, just anything observable before they walk into the ER that lets us identify potentially limited benefit, we're going to take out. And then we're going to divide the patients into 2 sets. There's going to be a 3/4 random sample of patients, not visits. So all visits from a patient get grouped into either the model training set or the holdout set. And we're going to train an ensemble model that's predicting the yield of testing as a proxy for the blockage risk in the tested, where we observe, near perfectly minus the imperfections of the test, who has a blockage. And all the results I'll show you are from that remaining set of patients that the model has never seen. Any questions on this? Okay. So first, we're going to look at the tested patients. So this is about like 4 or 5% of patients get tested. So we're only looking at these tested patients. And this graph shows you on the x-axis the model predicted risk in bins. So these are decile bins from lowest risk on the left to highest risk on the right. And on the y-axis, I'm showing you the yield of testing, like the probability that the test is positive and leads to treatment. The average is 14% positive. And if you translate that into a cost effectiveness estimate, you get about $90,000 per quality adjusted life year. This is generally considered cost effective under the threshold of, that's commonly used of about $100,000. But as you can see, there's a lot of variation around that average. So in this lowest bin, the yield is under 2%. putting that through the model, that's about $1.3 million per life year. And so this would clearly meet our definition of overtesting based on cost effectiveness. And in that top bin, you've got over a 50% chance of a positive test, and those are extremely cost effective at under, like even in England, this would be cost effective. And so this is very good value. Now, there's one thing I can tell you about these people. So these are the tested people, but we can generate these model predictions, of course, for everyone that walks in the ER, not just the tested people. The model has learned from the tested people, but we can generate predictions based on X for everyone. So if we look at people with this level of risk in this top bin of risk where they look very cost effective, we can just ask, well, when the model says these people are very high risk, how many of those people actually get tested and make it into this bin? About half. And so this might make you wonder if there is under-testing alongside over-testing, because a lot of these high-risk people are not being tested. Now, because there is selection into testing based on both things we see and things that we don't see, we cannot use this statistic to conclude under-testing. So what we've shown is that physicians fail to test patients that look high risk to the model. And there's a very nice paper by Jason Abelak and Leila Aga from 2016 that shows this with a related test for pulmonary embolus in people coming into the ER. The problem with with that strategy is that physicians can leave people untested for very good reason. So imagine someone who has a history of heart disease and comes in with chest pain. The model is going to say, oh, this person is at very high risk based on all the information I see, which ends at the ER triage desk, because that's the last point that we can make a prediction that applies to all patients in the ER. So we only use information up until the person checks into triage, because we want to simulate creating a tool that helps physicians make decisions about patients. And that's the last time we see the same information set about all patients. So now we're making a prediction that this, 65-year-old with a history of diabetes and heart disease with chest pain is high risk. Seems reasonable. The physician opens their shirt and sees a huge bruise on the chest and is like, oh, I know why you have chest pain. You got hit in the chest. So that's a good reason for leaving someone untested. The model would have concluded like, oh, this is an error. But the physician sees a bunch of stuff like that that we don't. And in the paper, we go through this example where we build in the electrocardiogram waveform into the predictions as one unobservable that's typically not included in these model predictions. And we show the huge amount of information that physicians are extracting from that thing that can't get included in the model. So there's lots of reasons to worry about this strategy of concluding under testing just from discrepancies. And what's worse is that in the tested, when the physician and the model disagree, oh yeah, go ahead, Stephanie.
Sorry, Stephanie. For this one, it would be so lovely if there were some arbitrary rules that lead for testing in some software or anything that would basically give you arbitrary variation to see whether the people that are quasi-randomly tested in this group have anywhere similar occurrence of like symptoms later than in, I mean, you're all very well aware of this. I wonder, maybe that's even where you're going, but.
Yes, I think that is, let me come back to that in 3 slides. So
one other point
yeah,
here.
go ahead. Yeah.
So just in the previous graph we look at, you're using these 16,000 features to predict risk in a very precise way. And I think you understand well, oh, that's asking too much of physicians. They're not going to be able to do that at the triage desk. I mean, just for inferring under testing relevant to moral hazard, it seems like the bar is potentially really far away from that level of precision in terms of what the optimal decision has to be. I mean, the main thing I'm thinking of is I think lots of hospitals have rules that if you show up and tell them I have chest pain, that they have to get you past the triage desk and hooked up to an EKG, I think within something like 90 seconds or 2 minutes, right? So it's, in terms of assuming that they don't change that rule, the best they could possibly do is not like, 16,000 features, it's like 2, like while they're walking to the EKG machine, right? And so, I mean, I'm 100% on board with thinking about a lot of misprediction, but for thinking about what this reveals about incentives, like how do I think about that?
Yeah, so let me distinguish between like two kinds of tests. There's all of the tests that you were just mentioning, which you're absolutely right. There are these rules that enforce almost over testing, but those are only things that happen in the ER. And all of those things are ECGs and lab tests and things like that that are suggestive of blockage, but not the test that we're talking about here. So here we're talking about these largely catheterizations that are the invasive procedure that someone gets referred to after all is said and done in the ER and all those things with all of their quirks gets done. The physician integrates all that and says, do I want to subject this person to this invasive, expensive test in the hospital? So it's true that there's a lot of like nudging, you could think about it, towards like, getting information and things like that. But ultimately the physician processes all of that and has to make this decision about this other test where they send the person to a total, and there's no enforced rules about those things. That's totally left up to the physician.
I understand that the specific point I'm making is if we're restraining ourselves to information collected at the triage desk, even though your focus isn't on that first step of like an EKG or something, that constrains the information collected at the triage desk. This could be just my idiosyncratic knowledge of a couple of hospitals, and you can tell me I'm wrong in general, but do you understand the nature of the question?
I think so. Let me try to say it back to you. But like, so your worry is that the model is not going to see enough information to make a valuable prediction.
No, quite the opposite. I think the model has access to enormous amounts of information. And as long as we say the triage desk has to complete in 2 minutes to get you hooked up to an EKG, the triage desk is really far away from the model. Like even under its, there's no state of the world where you could get anywhere close to the model. That's kind of what I'm getting at when we're thinking about what informs doctors' incentives.
I think I'm sorry, I'm being dense, but doesn't it feels like at the point of the triage, the doctor and the model have the same information. After triage, the doctor collects a bunch more information.
So I think your model has access to 16,000 features over 2 years. And I think the doctor would have to collect that in 90 seconds at the triage desk before they hook them up to the EKG.
Oh, but yeah, we're not enforcing that the doctor is making a decision at triage. The doctor has the whole ER visit to look at the chart and do extra tests and collect a lot more information. And all of that information is present in the electronic health record. So it doesn't feel like we're in a world where the model has more information than the doctor by any stretch of the imagination.
Got it. Okay. Yeah, I'm with you.
Okay. So there's this kind of empirical problem when we go back to undertesting and try to verify undertesting, that in the tested we see the test result, but in the untested we don't have the test result, and so we need to turn to these other measures to see who's right. And so there are two solutions. Solution one is we're going to go back to those adverse event rates that I mentioned, and we're going to look at, in people who look eligible for testing, what is the adverse event rate and how does that compare to the decision rule? And solution number two is Stefano's idea, which is to exploit quasi-random variation in testing rate to actually directly measure the impact of testing on health. So let me first show you the adverse event rate. So same x-axis, low to high risk. Y-axis is the rate of diagnosed heart attack or urgent treatment for heart attack, which we confirm with laboratory studies like troponin, cardiac arrest or death in the 30 days after the visit. And you can see that that is going up and quite steeply up in predicted risk among these untested patients. In the top bin, it's 15.6% adverse event rate over 30 days. The most lenient clinical threshold is 2%. So that's the rate at which the clinical guidelines recommend ex post these people should have been tested. And there are two components to that. There's the adverse cardiac events, which you might worry are dependent on measurement because the person has to come back and get measured. But there's also death, which we get from linkage to Social Security data. And death is, a third of those adverse events. And even if you just looked at death alone, you'd be well above the threshold for testing. So it looks like these patients that the model has identified at high risk are indeed high risk based on the adverse event rate. Now, there's one problem here, which is that, so doesn't seem like there's physician private information about risk, like that chest bruise example, like that wouldn't account for these results. But you could imagine another kind of private information, not about risk, but about treatment benefit. So we're showing you that these people are high risk, but physicians could be very aware of that risk and still decide not to test because these people are like frail or they couldn't handle the treatment in ways that we haven't been able to exclude based on X prior to showing up to the ER. So one thing we can do here is use the data we have from the ER, where the physician essentially tips her hand about whether she's worried about heart attack. So there are these tests like the electrocardiogram, troponin test that are very low cost and that are done on everyone that you have even the slightest suspicion of for heart attack. And even people that you're not going to treat invasively, you still need these things for monitoring. You need to know whether they're going to the ICU or the floor. You need to know how closely to watch them. There are other medications that you might give. So even in treatment ineligible people with high risk, you should see these tests being done. So we're going to use the adverse event rate in those unsuspected patients as a lower bound on the adverse event rates in people that the physician is not suspecting. Because here in these people, the failure to test can't reflect private information that the physician has about it. It's just the physician is not thinking about heart attack. So we're going to look at those two tests, the ECG on the left and the troponin, the lab test on the right, as a function of risk. And what you can see is that the fraction of people untested goes down. So as the model predicts higher risk, the physicians are doing more of these tests. But in that highest quartile of predicted risk, there are still about 20% who don't have an ECG and 40% who don't have a troponin. So there's a bunch of those people that the model thinks are high risk, the physician is not testing. And when we look at the adverse event rates in those people, the high risk untested people that the physician has not suspected of heart attack, they still have adverse event rates that are higher than the threshold. So even in these untested, unsuspected patients, we're seeing a high adverse event rate. So this doesn't look like private information about treatment benefit. Now, going back to Stefano's idea, what would be ideal is to randomly test some high-risk people and to just see if actually doing the test measures health. So we can't do that. We can take advantage of the copious practice variation in our medical system. And the basic intuition here is that you come into the ER at a particular time, and a particular team of providers are working at that triage desk. There's usually a doctor and a nurse who are doing rapid evaluations. And it just turns out that based on the shift that the team of people that you come in that's working in the minute that you come in, there's a ton of variation in the mean risk of being tested as a function of just who's working at the triage desk. The observables look balanced across these shifts. There's a ton of variation in risk at the same kind of test rate. So we've got a lot of the ingredients that we need for a plausible quasi-experiment here. And what we can do is first say, okay, so now we've got testing shifting up and down. So let's just look at the effect of testing on these downstream health outcomes. And so we're going to look, there's a bunch of things you can look at. We're going to just look at death in the year after the ER visit. So this estimate here is the effect of testing on death, and there's nothing. So this is kind of like the standard flat of the curve medicine story where like, yeah, you test more, you test less, everyone has the same outcomes. Why are we testing more? But that's the average effect. Now we're going to look at the heterogeneous effect by risk. And here what you can see is that there is a large and significant negative coefficient for the high risk people only. So, and this is corresponding to, in that top quintile of risk, a 30% reduction in mortality over the year after the ER visit if you arrive on a higher testing shift. So here, I think like this is, all of the other evidence I think is like suggestive but not definitive. This I feel like is a little bit more direct evidence that for those high risk people, not for everyone, but just for the high risk people, if you come in on a shift where you're tested more, you do better. So stepping back, I think the interesting question for me is what is the behavioral model here? So there's like the misaligned and yeah, go ahead.
Can I ask just a very kind of boring question on the previous slide? How do I interpret these? I was trying to figure out the magnitudes and the standard errors below. So the shift test rate on average is a 0 above. I get it. So, and then the predicted risk, what is it as a variable goes from 0 to 100, or I'm trying to understand what are the effects at the top quantile, bottom quantile.
Yeah. So it's a little bit, this is like effectively a reduced form where we just look at the test rate variation, 0 to 1, and the predicted risk, which is 0 to 1.
Okay.
And so the baseline mortality risk in that top quintile is, I think I should have had this in the slide, is about 7 or 8%. And in that top quintile of risk, you're getting a 2.5 percentage point lower mortality.
Okay.
And then in the lower quintiles, we're not seeing any difference.
Okay. And and you here, like you're approximating linear, even though in your graph it looked like it was rather.
Yes, this
so
is
in principle, it would not be ad hoc to just estimate the first stage of what you would have expected it to be like from this other sample and sort of use it here. It looks like, you have reasonable precision, but that, that would have been another way to do it. It wouldn't be, to me, wouldn't be in any way specification search.
Yeah, I think that's right.
Sorry, I said it was boring. Thank you.
No. It's a very good boring question, because I think we tried to get maybe later we can talk about why neither we nor ultimately the reviewers were that excited about doing the IV. It's a boring answer, but maybe let's talk about it later, because it'd be fun to get your thoughts on it. So the behavioral model here is, coarsely and to oversimplify, like the standard model is, there's an optimal threshold where there's a break even between costs and benefits, there's some distribution of risk, and the physician's job should be to test everyone over that threshold, because those are the people where it's worthwhile. The moral hazard model is the threshold moves down, and you end up with low average yield, because in addition to testing all of these orange people that you should be testing, you're also testing these purple people that are lower yield, and you're diluting your yield. So that's why you get low average yield. In a misprediction model, there's an assumption that we can unpack, which is that the moral hazard model implicitly suggests that physicians are ranking people properly when they set the threshold. But if physicians are not ranking people properly, then the risk distribution is just going to be, it can be arbitrary. And so you are going to get low average yield because you set the threshold and you think you're testing high risk people, but you're actually getting a mix of orange and purple. So that's going to give you low average yield, but it's also going to give you orange people under the threshold. So you're also going to get untested high risk patients in a misprediction model, but not the moral hazard model. So, I think, what this suggests is that we should actually directly start looking at the nature of misprediction to try to understand what this model looks like in practice. So basically, our playbook is drawn from this long tradition of clinical versus actuarial risk model. And we're going to start looking at how physician decisions deviate from risk. So we're going to use the testing as the physician's revealed risk estimate. And then we're going to look at the model estimates, and we're going to compare. And we have two hypotheses that we're going to test. The first one is that physicians use a too simple model of risk because they can't attend to or process or whatever all of this complex risk information that they have access to. And the second is this different world of errors and biases where physicians might be misweighting specific variables that may or may not matter for the true risk. So finding number one, we're going to tackle actually by making the analogy between the physician's risk model and a machine learning model. So we're going to create best fit risk models of varying complexity. And what I'll show you is lasso, but this isn't specific to a particular functional form, but we get the same result with trees, but lasso is just easiest to think about. So we're going to train a model to predict risk using a lasso. In other words, like going from very few variables to lots of variables as we vary the penalty for including more variables. And we're going to use that as our measure of model complexity. So now we've got a risk model of varying complexity, and we're going to see how well those models predict actual patient outcomes and physician test decisions. So this graph has that complexity measure, the non-zero variables in the lasso on the x-axis. And on the y-axis is the R squared for predicting true risk. In other words, did the tested patient go on to have a positive test? And for predicting the physician's testing decision. And what you can see is that they both have that characteristic machine learning graph thing of like prediction gets better and better and better, and then you start overfitting, and then you drop off. But the place where it starts to drop off is much earlier for the physician than it is for the model. So the best risk model is 200 plus variables. The best physician model is 49 variables. So there's a clear difference in complexity between the best model for predicting risk and the best model for predicting the physician's decision-making about risk. A very kind of like simple way to show that is to turn this figure into a regression and say, okay, we're going to partition risk into the simple risk that's predicted by these 49 variables, and then the incremental risk, the full risk 224 variables minus the simple risk. So there's the simple risk, and then there's the marginal risk estimate that you get from adding all of these other variables into the model. And what you can see is that the simple risk in column 3 predicts yield of testing very well. When you add in the incremental risk, that also helps predict the yield of testing. But there's no added value of that incremental risk for predicting the physician's decision of whether or not to test someone. So I don't think this is like a formal test. I know I'm speaking to a much more sophisticated audience than I am. I don't think this is a formal test for bounded rationality, but it's I think, suggestive that there's signal for predicting risk that physicians are leaving on the table by using a too simple model of that risk. So Colin Kemmerer has this really nice paper that makes the analogy between what humans do and what good machine learning models do, which is that they regularize. We can't attend to all of these variables. And so we actually kind of do a pretty good job of regularizing down to a small set of variables and using them very well. And I think that there's another interesting parallel to the original actuarial clinical judgment papers, which is very, very different from what we find. So in that world, people are too complicated. They're over-reading signal into these things. There's a lot of noise, and they should actually not do that. They should be simple. And that's why the statistical model does better. It's because the statistical model uses 5 variables with simple weights, and you should just go with that one. Humans are too complex. In our world, we're actually finding the opposite, that physicians are using far too simple of a model. And the key to the statistical model's improvement is that it is more complex. And part of this is, there's another really nice paper that I think is either out or coming out about the illusion of sparsity, that takes a bunch of macroeconomic phenomena and tries to model them with simple models, and finds that it's the exception rather than the rule, where a simple model works better than a complex model when you have very complicated phenomena in the real world. So even though we humans have a preference for sparsity, the world doesn't necessarily have a preference for sparsity in the same way.
Can I ask a question on this?
Yeah.
Like in your plot, it looked like for the machine learning model, the 220 feature one and the 49 feature one are not really statistically distinguishable in performance. Like, because it's like kind of flat and there's like a huge error. Is that, am I interpreting this wrong?
No, not at all. And I think that like partially it's because the true model, or at least our better models, are actually very interactive and not linear. And so this is a lasso. So there's a similar result for trees where it's like tree depth and stuff like that, but then it's just harder to show on one graph.
It's just like misspecification.
I think this is just misspecification. I wouldn't read too much into the,
And like building on this kind of, if you look at the regression, you do, it's kind of striking that you get a similar coefficient on yield in column 4 for the incremental versus predicted, but the added R square isn't huge. You go from 2. Yes. So basically you do a little bit better, but you don't improve predicted accuracy a ton. So it is really cool, as you said, that the complex models, you don't get the old result of the linear thing is right. But if adding those extra variables took a significant share of time of the doctors and crowded out something else, then it wouldn't be worth it. But of course, if like the software incorporated for free, it would seem to be worth it. So I mean, I think that's where the magnitudes that also Hamza's question matter. You both want to know that it does better, and it's clearly there. At the same time, it's also not like economically huge in a way that you would say stop everything and do this.
I think that's so totally right if we're talking about metrics like R squared, that I think is what we're using here. But remember that R squared is a statement about the whole distribution. And what we're interested in is the top tail of that distribution for risk. So I think that like and we probably should have done this in the paper, and I wish I'd asked you sooner, all of you, but I think that that's where the model really shines, is in that top part of the distribution. And these metrics are just intrinsically integrating over the entire distribution, where I think the benefits get diluted. Okay, so the physicians could be using a small set of variables, and that could give us a high, R squared, but they could be completely misweighting those variables. So we haven't shown you that they're we've shown you boundedness, but not necessarily rationality. And so we're going to take those 49 variables in the physician's simple model, and we're just going to look at univariate correlations of each of those variables with true risk on the bottom, on the x-axis, and the physician's testing decision on the y-axis. So this is a kind of like crude test for, are physicians weighting those variables basically appropriately in their testing decision relative to the single variable's correlation with risk. And what you see is that actually, like, overall, the weights are correlating pretty well. So physicians largely appear to be like weighting those variables right. But there are also some outliers. For example, the one up at the top here is chest pain, way overweighted for the test decision relative to risk. So it's on the right part of the risk distribution. So there is a lot of signal, but physicians are overweighting it. Age is similarly overweighted, whereas things like female sex and low income appear to be underweighted for that testing decision. So even though there's a good R squared, it's positive, it looks okay, there are also these outliers that suggest that physicians could be misweighting systematically some of those variables. Now, symptoms and demographics, I think, were the ones that stood out for me. And I think that it's no coincidence that these are the first things that physicians see about a patient. In fact, when you work in the ER, like a new patient coming in is like something pops up and it says Mrs. whatever, 63-year-old female, chest pain. So that is literally the thing that is compressed down and showed to the physician in that initial impression formation. And I'm sure you've all read through the case records of the Massachusetts General Hospital, but this is kind of like how medicine is taught. And you can see that, like, in all of this medical education, they also reduce the patient down to age, sex, and symptom. So this is a pretty universal fact about how medicine is taught and conceptualized and how we think about patients. Like in the ER, you're often referring to, like, oh yeah, the abdominal pain in room 7. So this is kind of like a very universally salient thing. And so here's our test for those things. We're going to repeat our entire machine learning pipeline, but we're going to restrict the set of X's to certain categories of variables to get a risk score that is only the risk from symptoms, only the risk from demographics, only the risk from. So if you restricted to a certain category of signal in these clinically coherent groups, you would get a risk predictor. And then we're going to see if those particular risk estimates that are handicapped by only looking at one type of signal predict the physician's testing decision over and above what they should according to risk. So those are these, so top row is our full machine learning model. So this is like our best risk predictor that integrates across all those categories. And then we add in the risk prediction that's only based on symptoms. And you can see that that has a huge positive coefficient that indicates that physicians are loading a lot on the risk information from the symptoms, in addition to the risk information from everything else. Then we can repeat that with a bunch of other categories. So demographics are also overweighted on that metric. And these complex quantitative time series, like laboratory results and vital signs and things like that, appear to be underweighted. So physicians are attending to things differently. And then I think a really interesting thing is there's also this idea, Andre has and co-authors have a bunch of work on representativeness and stereotypes. So we can look at the symptoms that are overrepresented in people who are found to have heart attack versus other symptoms. And we can do that empirically. So we group symptoms into ones that are representative of heart attack and ones that are not. And we find that almost all of the signal from that symptom comes from this small set of representative symptoms like chest pain and other things like it. So let me close by summarizing and saying that I hope I've convinced you that misprediction is a driver of both over and underuse. And quantitatively, it's quite important because under our preferred counterfactual policy, we would keep 38% of the tests that physicians are currently doing by our cost effectiveness estimates, but we would add in the equivalent of 16% of tests that they're not currently doing on untested patients. So this isn't a question of like, how much testing is there? Are we testing too much or too little? It's a question of who is being tested. And I think that really echoes a lot of emerging literature, that there are richer models of the ways physicians think than incentives alone. So our focus is complementary to that literature, but focuses on these predictable errors that come from potentially boundedness and biases. And I think the last thing I'll show you empirically is this result graphically. So on the y-axis of this graph is the test rate. On the x-axis is our predicted risk. And I'm just showing you that natural experiment setup where I've grouped patients by whether they come in on a high testing shift or a low testing shift. So those are the 4 bars. So you can see that in relative terms, physicians are cutting a lot of wasteful tests when they move down the testing likelihood. But they're also cutting a ton of very valuable tests. So it's just shifting everyone up or down. And we see the same thing when we categorize hospitals nationally using these hospital referral regions. Low testing hospitals test everyone less, high testing hospitals test everyone more. So I think this is a very general result that we see in the academic hospital that we studied, in the Medicare data. And I think this shows that the problem with incentives is that incentives can get you to test less or test more, but they can't get you to test better by torquing the slope of these lines. So let me end there, and I'm happy to stay on a little bit longer if people have time, but also happy to call it a day.
Actually, we should probably call it a day for, I know at the very least, Stefano and I have a faculty meeting we have to go to. So, but thanks everyone very much for coming today. Thank you, Ziad, for the great presentation, and thanks to our audience for attending. We'll be doing all this again next week. Hope to see you then as well.
Thank you so much.